The morning breeze has secrets to tell you. Do not fall back asleep. You know, I just spoke at a dental meeting, and I got one of the best evaluations ever. And I like to share it with everybody. If I only had 6 hours to live, I would definitely take your course again. After sitting there all day, it seemed like a lifetime. You know, I'm one of the lucky ones. I've been working with Dr. Gordon Christensen for over 20 years. And Gordon and I were on a fishing trip. It was Gordon, the guide, and myself. And the guide leaned over and said, "So what do you do?" It was my time to hear what Gordon would say of himself. And he simply said, "I teach dentists. I teach dentists." Later on, he would tell me, "Mike, I want to help as many dentists as possible to serve their patients with more expertise and enjoyment." And today, I share that goal of teaching with Gordon as project director, chairman of the board, and clinical evaluator of Clinicians Report. We have 450 evaluators worldwide testing these products and techniques. We have two goals at Clinicians Report. One is to identify products, concepts, and techniques that are faster, easier, and higher quality. And if it matches all three, we'll look at the cost differential. And then to communicate this information to the profession. So today, I want to identify one of the best intraoral cameras on the market. We're going to look at a problem we're having with zirconia. And then finally, to offer a significant way to treat your patients for their pain without narcotics. So let's look at intraoral cameras. Why would I want one in my practice? Two reasons. One is documentation. I'm challenged because insurance companies are now saying tooth did not require a buildup. So what are we doing? We're documenting the tooth and sending that to the insurance company. Digital radiography is wonderful, but it's having a problem to detect interproximal caries. So we'll show this to the insurance company. But there's also the education component. We want to educate our patients. We do an intraoral camera tour of the mouth. So we looked at intraoral cameras at Clinicians Report, and we were intrigued by the online low-cost cameras. Now certainly, Digital Doc is one of the better cameras on the market, but for thousands of dollars, we looked at Mouthwatch. For $299, it was disposable. You could put one in every operatory. It provides a sharp, crisp image, and it's easy to use, and it integrates with all dental software. So we have some breaking news. We need to respect occlusion, especially when it comes to zirconia. We looked at 5 mistakes of zirconia. Number one was us as clinicians. We're providing inadequate tooth preps for the laboratories. The number one component, lack of occlusal reduction. We're doing a study now on aesthetic zirconia. Dr. Rella Christensen has chosen evaluators from all over the country to prep these teeth and then send them in. Her first directive, please provide the proper amount of occlusal reduction. And remember to follow the plane of occlusal anatomy so the lab has greater design flexibility. An ideal prep has 4 millimeters of axial wall height, a 2 millimeter ferrule, and you want to keep your preps less than 20 degrees from parallel. So let's look at what an adequate zirconia preparation looks like. At the margin, you want about 0.5 to 0.75 millimeters of reduction. You want a light to moderate chamfer, about 1 millimeters of axial wall reduction. But here's the catch. Occlusally, we want 1.5 millimeters of reduction for zirconia. Well, wait a minute, Dorociak. I thought we could get it down to 0.6 of a millimeter. Well, we have a problem here. It's the labs. The labs are providing a dye spacer. That's up to 0.5 millimeter. Then the labs will often keep the crowns too low. They'll have an occlusal accommodation of up to another 0.5 millimeter. So if the lab is taking 1 millimeter of space, I need to provide at least 1.5 millimeters of occlusal reduction. This will provide greater design flexibility, strength, and occlusal thickness. So the preparation on the left is a preparation for full zirconia. What's the preparation on the right? Lithium disilicate, which requires a more aggressive prep for both strength and flexibility. You want to use a round, tapered diamond to produce that chamfer. You want to round your edges, and you want to avoid a knife or feather edge margin. Avoid square right angles. So what can we get on a limited budget? It's the disposable or low-cost diamonds. When we studied these diamonds, we found that they were clinically indistinguishable from the premium price diamonds. Why do I like a low-cost diamond? I can use a new diamond for every procedure. It's a sterile diamond. They're often sterile packed. And where do I want them also? When I have to use multiple diamonds, when I'm cutting off a zirconia crown. So you remember that old family circus where the kids would get in trouble and they'd say, not me, not me, it was a ghost. So here's the clinician up here saying, lack of occlusal reduction, not me, until this patient came in. They had worn through the zirconia. I didn't provide enough room. Well, why do I like this? This shows me that zirconia wears. I like that. The opposing enamel will wear the zirconia, and the zirconia will wear the opposing enamel at about the same rate. Remember the old feldspathic porcelain? It would wear the opposing teeth up to 7 times. So I will often use these prep shirts. They're occlusal guides that will make sure that I provided the proper amount of occlusal reduction. I can bring it from distal to mesial or mesial to distal. I had a patient walk in. He was a pharmacist. His name was Lou. He said, I'm coming to see you because you're a good dentist. I said, Lou, how do you know I'm a good dentist? He said, because of the lack of pain prescriptions you write. We have an opioid crisis. It's now the major cause of death for those under 50. So my most potent way to provide pain relief is to combine ibuprofen and acetaminophen. I'll start the patient out with 3 tabs, 600 milligrams of ibuprofen and 500 milligrams of acetaminophen. This provides tremendous pain relief. And after the first 24 hours, we'll reduce the amount of the ibuprofen. Now, occasionally I have a patient that says, oh, I want a prescription. Do they really need a pain medication? Maybe not. So I'll prescribe Tramadol or Ultracet, 2 tabs every 4 to 6 hours for pain. So in conclusion, if you've been to the Vatican, you might see Michelangelo's Pieta, often considered one of his greatest works of art. But he did it in his 20s. Many of the townspeople didn't believe it was him. So what did he do? He sculpted across Mary's sash. Michelangelo Boronatus of Florence did this. And in case you're wondering, Michael R. Dorociak of Sarasota, Florida did this. Remember, clinician's report has your back. My strength is to bring the research from a clinician's report and combine it with my clinical expertise, because the greatest part of my resume, I'm an everyday practicing clinician, and I bring real-world dentistry into your lectures. Because if the only prayer you ever said in your entire life is thank you, it will be enough. Thank you.